The broadcast is now starting. All attendees are in listen-only mode.
All right, everyone, thanks for joining us. We're going to go ahead and dive into today's session. Today's session is also going to be recorded, so if you would like a copy of that, feel free to reach out and we can get you a copy. Normally, we send it as a piece of the follow-up. Today, we're going to be talking about mental health parity and addiction equity. This is a compliance update as much as it is maybe anything. A lot of people that are on this session, there's interesting mix between people who work at with TPAs, at a TPA, or employee benefit brokers, people who work for PBMs. This is a group that's a little bit of everyone who, just like us, is in the midst of trying to make sure that we are maintaining compliance on behalf of our clients. So I'm going to also provide this session to you. I will make sure to drag and drop it into the session so that you can download it. Actually, if you would bear with me, let me just do that real quick. I'm going to do that. All right, so you should have access to it now so that you can download the session. I would ask you, just as a housekeeping note, please send in your questions. The last session we did, we had a chance to get to these are larger sessions with lots of people on them, but typically we can make it through most of the questions, if not all, especially if I get them early, because I can know kind of what you guys are thinking and answer a lot of the questions along the way. So without further ado, let's go ahead and we're going to dive in. Okay, so the following, just as a side note, the following is intended to be used for general guidance purposes. I'm not an attorney. I'm not playing an attorney on YouTube or anywhere else. Please make sure to point any questions regarding legal questions or tax questions to your legal counsel. Okay, now that that's over with, we're going to talk about this agenda. What's a little more daunting than it is. I've broken it up just to try to make this as understandable as possible. We're going to start out by reviewing mental health parity and the Addiction Equity Act updates. Initially, it was mental health parity, and then with the other legal updates along the way to get us to MHPAEA, which is a pretty long acronym in and of itself. So we're going to talk about really that the act itself. We're going to talk about what the requirements are. Then we're going to talk about when this is due. You'll notice it says, when was this due? That's because, why am I saying that? Because this should have already been done, right? Who does this apply to? Who is the responsible party? What is a comparative analysis? What are quantitative treatment limits and non-quantitative treatment limits? And then finally, what overall are the risks that are associated with this? Okay, so first of all, who are we that we even have an opportunity or the any credibility to even have this conversation? You know, as we looked at this, this is becoming a division of self-insured reporting. And we looked at it, we were thinking, my gosh, if we don't do it, who in the world is going to do it? Our background, a lot of you guys on this session likely know our background at ACA reporting, Sky ACA reporting, and Sky Insurance Tech. I'm getting notes that you guys might not have any audio. All right, if you guys can hear me now, can someone send me a note? I'm not sure what I've missed or if I accidentally hit that. Can someone shoot me a quick note that you can hear me now? I'm showing that that the audio is showing up on my side. Let's see here. The only notes I have thus far in terms of questions or chats is that you guys still cannot hear me. So if someone can, is anyone there? Yes. Okay. All right. People can. All right. No. Now we're getting a bunch. All right. So good. You can hear me. All right. So I apologize. I'm not sure if I hit something. Let me just cover real quickly this just in case. We're not attorneys. This isn't legal advice. Here's the overall agenda. This is kind of broken up. We're going to go through all of these items. This is in the handouts, which is in the control panel. And so you can download this. Who are we? A lot of you guys on here know us from the compliance work that we started in 2015. And good. And I hear some folks that said they've had sound all along. So good. Maybe it wasn't a problem. So compliance services, ACA reporting, and then when you combine that with the fact that what we do on self-insured reporting, you start understanding once you dig into these regulations, we started going, oh my gosh, if we don't do it, who in the world is going to do it? Because you really need to have both. Completing this analysis requires understanding of self-insured claims, and there's a lot of quantitative type stuff in it, as well as just understanding compliance. Also, too, when, in ACA reporting, when we all started that, we went from no clients to, I think, almost 1,000 in 9 months. That is everyone trying to run out of a door at a movie theater at one time. It was an experience, but that's kind of what's happening here too. You're going to see why here in just a second. Okay, reviewing MHPAEA, Mental Health Parity and Addiction Equity Act. This is a federal law that basically is all about you have to treat, a plan sponsor has to treat mental health and substance use disorders the same they treat medical and surgical benefits. That's really the gist of what we're talking about. Now, how you go about applying that, and most people understand this. They're like, yeah, I mean, I get that. That's been around for years at this point. MHPAEA is the acronym. It was amended late this past year in December of 2020. And it was amended by the Consolidated Appropriations Act of 2021. They do that kind of stuff. Like at the end of 2020, they pass a bill that has 2021 in it, just so that we are all more confused than we were in the beginning. But really what this was all about in them doing it was all about trying to get compliance, because in reality, people weren't paying attention to mental health parity. That's really what the gist of what kind of came down. So MHPAEA, first of all, does not require that a plan provide mental health and substance use disorder benefits. However, I mean, let's be real here. Almost all plans do. It doesn't require it though. But what it does just say is, okay, if you are offering it, and there's some specific rules about how you're offering it and determine if you are, you got to really do it. And there has to be real parity. Now, I was an employee benefit broker for about 15 years prior to selling my agency and kind of getting into serving the industry in a different way. And so, and I've been obviously very connected through self-insured reporting as well as ACA reporting with brokers. And so we see the day in, day out stuff. People get this. I mean, people understand, but in reality, when you start looking at the way that these plans operate, there hasn't been parity, not even near parity in quite a long time. And so what these efforts are all about doing is saying, we're not doing that anymore. And I'll tell you more about that here in just a minute. But group health plans that offer mental health, substance use disorder benefits, they have to be in parity in 3 areas. There are what they call broad financial requirements, treatment limitations, QTLs and NQTLs. These two acronyms you're going to get familiar with and comfortable with, whether we like it or not. And then aggregate and lifetime dollar limits. Okay. So when was this due? This was due 6 months ago. Plan sponsors must perform a detailed and ongoing comparative analysis containing a, quote, robust discussion of all sponsored plans to ensure that parity exists. So basically in the past, I may have one in here about what the DOL will not take. But let me show you. I'm going to toggle on you real quick. NQTL analysis. This NQTL has become kind of the overall main challenge. It's not really the only challenge, but the quantitative is pretty challenging as well. But you can go to nqtlanalysis.com. Up here at the top is a frequently asked questions. This is phenomenal. Like this, even if I played a part in putting it together, we're humble too, right? No, seriously, this is really good. This is the majority of the questions that you're going to have that pop up. So it's a great resource for you. But robust discussion. What they're not going to take is, in the past, what they've done is people have said, yeah, we're compliant. And they start looking at the way that the plans actually operate, and they go, no, you're not even close to compliant. And so this comparative analysis that was required to be done 6 months ago, it is so interesting, y'all, from where I sit. I've read these regulations inside and out at this point, and I'm going, what are people thinking of? And I think that there was a lot passed, right? You have the Surprise Billing Act, you have the transparency stuff, we have broker commission transparency. There's a lot of stuff going on right now. But this is a serious one, and this one is not going away. And it was due 6 months ago. Okay. So the DOL is not going to accept these generalized statements anymore. This is their language about compliance without a detailed supporting evidence and explanations. And they're not going to take insufficient evidence anymore. And where this all came from are really three different areas. First of all was DOL audits. They were pretty much appalled when the DOL went and did audits. Now, where am I getting that from? When, it's interesting that the people we end up having the opportunity to talk with is just so diverse. And so this is coming directly from people that have that are in Washington, connections in Washington, people that are connected with congressional staffers, people that are connected with the Department of Labor. And the bottom line is when they started going out and looking at these, and doing these audits, they were like, this is ridiculous. I mean, these plans aren't even remotely close to parity. And they are extremely serious about this. Someone said here recently that the DOL just received what they call an enforcement boost. This is in the new budget proposal that I think it's a $2 billion increase. They're looking to increase enforcement staff by 2,300 people. So enforcement, they're getting very, very serious about enforcement. The second is budgetary impacts. And there's a lot of lobbying that occurs on the backside of all of this stuff and trying to get Congress to do certain things. There's significant impacts that they're making very compelling arguments in terms of state budgets in regard to Medicaid. So their whole, the big argument is, okay, well, if we end up tackling these issues the way that they are supposed to be tackled, then we're not going to have all these problems. And, at least in terms of the Medicaid, we're not going to be the ones paying for it. And so what they're thinking is that a lot of care is put off and could have been handled earlier and not hit the state budget. And there's just overall significant lobbying, obviously, as a post-COVID world. Mental health is on the top of basically every survey and stuff that people are looking at. It's a massive focus right now. Okay, so to who does this apply? It applies to fully insured and self-insured plans. Basically, just about any group plan that's offering mental health and or substance use disorder benefits. Churches do not have exemptions. Public entities do not have exemptions. There was actually an amendment to something called the Public Services Act and an amendment to ERISA to make sure basically everyone has to comply. There is a small employer exemption, which essentially says employers with less than 50 employees, after you control, you guys know the whole Affordable Care Act, ACA control group rules and all that. You have to apply all that. But small employers are exempt. But then there's a part of it that says small employers are not exempt if they purchased an insured product with essential health benefits as was required by ACA. So even that's super technical. Here's kind of how it ends up shaking out, though. You end up having self-insured plans and fully insured plans. This is really the way that I think you should look at it. Self-insured plans, who is responsible? The plan sponsor is responsible. The plan sponsor is going to need to rely upon their vendors. They're definitely going to need to rely on the vendors to get some of the information that's necessary to do the comparative analysis. And this comparative analysis that we're going to go through is, you can I'm going to go through it, but this is what we're talking about. This overall, these three broad areas of broad plan treatment value limitations, quantitative limits, and non-quantitative limits. You hold the ultimate responsibility for that. In fully insured, you kind of are sharing responsibility. Now, the insurance carrier is supposed to be doing all this for you. That's kind of the way that they've got it set up right now. But it would be prudent just to make sure that they are, because I guess technically it's still the employer's responsibility, but obviously under a fully insured arrangement, the carrier knows everything. They know everything to do the work here. Like they know the network, the way utilization management is happening. They control the PBM. They control all medical management, utilization review. They're controlling everything. And so reimbursement to providers, all of these things that are required in this comparative analysis. And so, but when it comes to self-insured plans, all that stuff is broken out. So you can think, okay, well, who all is going to do this then? If it's because you think about networks and utilization management and PBMs and all the rest, all the vendors that are providing services have to be considered in the overall comparative analysis, and they have to be documented. So what are we talking about in terms of comparative analysis? Well, the first is a pretty easy one, but it's in here. It's annual and lifetime limits. Now, this isn't an issue, right? Most of this was handled in the Affordable Care Act in terms of restrictions on annual lifetime limits. For the incredibly nerdy, there are some little rules, just like anything. There's a couple of little rules in here, but for the vast majority of people, this is not going to be an issue. But there are what they call the 1/3 and the 2/3 rules but for all practical purposes, these things have been removed a long time ago. But you certainly cannot have restrictions on annual lifetime limits in terms of mental health and substance use disorders. Okay. Then we go into the second piece of it, the QTLs. Simply put, these are things you can put a number on, a quantitative treatment limitation. So I'm going to read this to you. Plans cannot impose a financial requirement. So what is a financial requirement? Copays, coinsurance, maximum out of pockets, anything like that that you can put a number on. Or it could be number of visits, number of inpatient days. You can't apply any of that to mental health in a way that's worse off than medical and surgical. It's a pretty straightforward, right? So what are they saying? They're saying parity. It has to really legitimately be an equal kind of thing. Now, let's give an example. So it's acceptable, for instance, to impose a $20 copay for mental health and a $10 for primary care visits, as long as the copay for most of the medical surges covered by the plan is $20 or more. And so what are they saying? They're saying, all right, well, and there's some complex rules, but this is all about parity. We're going to look at the copays that you're charging for mental health visits, and we're going to compare those to what medical and surgical looks like. We're going to do the same with deductibles. We're going to do the same with copays and overall coinsurance out of pockets. Now, the rules to do this are complicated. That's the bad news. The good news is it's math. You can get it done, but it's pretty complicated, because what you have to do is, first of all, you have to take expected claims. Well, by definition, expected claims haven't happened yet. And so what does that require? That requires actuarial assumptions. So now you're probably like, okie dokie, I can understand why self-insured reporting is involved in this now, because we do a lot of that work, right? It's if you haven't seen our platform, those are things, midpoint to midpoint underwriting and financial projections, and that's the kind of stuff and we're pulling in claims data, because like you can think to do all this. This has to be done, by the way, on a group specific basis. This has to be done based upon the actual claims, not a block of business claims, this group's claims, statistically and actuarially on this group's claims. So what you have to do is you have to break all of the claims out into 6 categories: inpatient, in and out of network; outpatient, in and out of network; emergency care, and prescription drugs. There's also some further classifications that if you have direct contracts or more than 2 network tiers. There's also a sub-classification to where for outpatient, you can separate out office visits from everything else. Confused? Yes. Right. So, like, what are we going to do? Let's just take an example. Inpatient in-network. There's lots of stuff that in there. That could be surgeries, it could be ambulance, it could be all those different things. And we have to figure out of all those little things, we have to apply two rules called the substantially all and the predominant test. And so, again, this is based upon expected cost. But what are we doing? We're essentially going, all right, back in this category here, this inpatient in-network, we're going to look at copays. Let's just take the deductible. We're going to look at the deductible and say, okay, what's a $1,000 deductible? Does that $1,000 deductible apply to substantially all the claims that happen here? And we have to show the math. Like, all the math has to be there to be able to validate. This is the robust discussion, the quantitative treatment limitations, and how does the math work out for this $1,000 to substantiate that, okay, we're doing that. And then there's also a predominant test that comes into play, which is a little complicated. But the long and the short of it is about, okay, if there's a $1,000 deductible that applies here to substantially all, and it meets the predominant test also, then when we start talking about inpatient for mental health and substance use disorders, the deductible cannot be more than $1,000. Okay, so, or if you, let's say over here, and you're putting in a visit limitation on mental health and substance use, and they'll go, okay, well, do you have a visitation limit? First of all, they're going to say, well, how'd you come up with that? Like, the evidentiary standards, the rules, how did you come up with that? And you have to have an answer, right? It's a documented answer that has to be part of this overall assessment that's being done. But again, it's just about doing all the work necessary to ensure that there's parity. Okay. Now, if you weren't confused yet, you're about to be. Non-quantitative treatment limitations. These are softer things. These are different ways that you can limit what treatment is and how much care someone gets for mental health and substance use disorders that don't involve numbers. So, okay, well, what could that be? I'm going to read a few of them. Medical management standards, any type of utilization review, any type of concurrent review, any efforts to exclude benefits based upon medical necessity for appropriateness or what have you. So, like, let's say someone wants to get into inpatient in mental health. And let's say, for instance, they have to say, okay, well, based upon this person, is this treatment experimental? Is this investigative? Is this person, like, are we looking at the fact that, they're going to have to prove that they're going to get better in this treatment? Who is the person? What are the credentials of the person that's making those determinations for mental health? And then they're going to turn around and say, okay, now what are you doing on medical and surgical? You're not doing any of that? Well, that's not parity. And so this is where the DOL got way sideways, and basically lobbied for compliance, that we need additional resources. We need more legal stuff out there as far as requirements on plan sponsors to get this thing done. Then we get into things like the formulary design. What are the drugs? Are you sticking all mental health and substance use disorder drugs into the third and fourth tier copay? Are they specially? As a side note, you might find this interesting because there's a lot of brokers on this call. I saw something actually in a webinar that said the current estimates are that by 2030, it's 2021 right now, so by 2030, that the cost for mental health and substance use disorders will exceed diabetes and cancer combined. Now, that to me seemed like a lot, especially because I was thinking about Sun Life did an overview of their 2020 stop loss claims, and the largest, I can't remember, like 6 of the top 10 things that were cancer drugs. And so I'm thinking, oh my gosh, like, this is going to be worse than cancer and diabetes combined. That's a lot. And that's really what they're talking about. So that's why parity is becoming a super huge focus. So what are the standards for provider admissions? Okay, you go, well, there's fewer mental health and substance use disorder providers than there are medical. There's even language in this thing that says, we don't care. You're going to have to add more, because you're going to have to be able to substantiate why are they, how do you come about determining who gets in the network? We look at reimbursement rates. I'll show you that. They're going to have to compare what kind of reimbursement rates are you giving the mental health providers and substance use disorder providers as opposed to medical and surgical? How do you compare it versus one another? How do you compare it to Medicare? How do you determine what's usual, customary, and reasonable in terms of charges? What about refusal to pay or step therapy? How is step therapy being applied? Is it being, so every one of these little things has to be pulled out, analyzed, identified. Now, I don't know if you guys have noticed this, but this stuff changes, right? The way that these things are being done by vendors, this isn't static. What I'm saying, this is not a once you've done it one time, you're done. It may be harder, certainly, to do it for a first year. And when you change to new vendors, certainly a little more work, but this is an ongoing deal because you're having to look at reimbursement rates on a regular basis. We have to go in, request from the TPA denials for mental health and substance use disorder and compare that to medical and surgical. So you think about it, it really wouldn't be parity, or it certainly would raise some eyebrows if 40% of all the mental health and substance use disorder claims are declined, or they're not approved for care, but it's only 5% for medical and surgical. You'd go, hang on one second. Like, what are the standards? What is the evidence being used to come up with this stuff? Exclusions based upon failures to complete treatment. Talked about network tier design, for anything in terms of the PPO, any type of restrictions based upon getting care only in a geographic location. I've seen this one actually not too long ago with some medical and surgical, to where a person was just, they were getting some care in lots of different locations, and then the person was like, hang on one second, you're just getting care in lots of different states. It's like, well, you don't tell people they can't do that, and they can do it at medical and surgical. You don't have a choice. And so these aren't everything, but these are just a few of them. This is directly from the DOL. The comparative analysis must demonstrate that the processes, strategies, and evidentiary standards that apply to mental health and substance use, both in the way that the plan is written and in the way it actually works, are the same. They're in parity. Okay. So what am I saying? Oh, all of these NQTLs, everything that you're doing in the plan and all of your strategies about medical management and all that, it has to be applied comparably in parity to to mental health and substance use as it is to medical. Of course, you can read this, but that's my Southern way of trying to make it a little more understandable. All right. So what is the comparative analysis? You guys can read, but this would be an example. Coverage for outpatient visits and inpatient hospital visits, and looking at, I actually won't go through these examples because I think I went through enough kind of with that in my prior rant, if you want to look at it that way. Pre-authorization for prior approval, looking at penalties for failure to obtain a prior approval. Every one of these little things has to be pulled out and analyzed. As a side note, there's also state laws that more and more are coming into play. We're getting more and more guidance in terms of this. I want to show you this piece in the comparative analysis. This is actually, let me first of all tell you where this guidance is even coming from. If you go to compliance options, and then you can see this DIY, do it yourself. This is what we have right now. This is in terms of guidance. I heard an attorney say not too long ago, he said, well, we really don't have any guidance. Well, he's, with all due respect, really wrong. This is 39 pages of exactly what they said that a DOL auditor uses when they go in and do an audit. I will tell you also, too, that as a standard item that DOL is requesting when they do audits, no different than how they request 5500s and everything else, they're asking for this. And so this is not going away. This is a thing. But basically what we've done as an organization is understanding that, okay, we can use this. Is this perfect? Is this as nailed down as ACA reporting was? No, not exactly. And we are going to get more guidance. We think in about the next 12 months. They're saying right now, it seems like they might go off of the New York kind of model guidance, some laws that were passed the end of last year or early this year? And if so, then what that's going to mean is annual reporting. I've also heard that it's possible the DOL is just going to issue out a whole bunch of letters just to people, not really like an audit, but just say, hey, send me your comparative analysis. So we just want to take a look. Now, they may or may not look at that, but you know, what's their whole point? To get the marketplace understanding this is not going away. But you can take a look down here, actually, way on page 38, to warning signs, reimbursement warning signs. And basically, this is of us having to look at certain CPT codes. If you're not familiar with that, that's a procedure code. And, you know, see how these things shake out and comparing neurologists, for instance, to psychiatrists. Are we, you know, how much are we paying for these same CPT codes? Are we paying these other medical and surgical specialists a higher rate than we are mental health? That won't fly. Then as a second step, we actually have to compare it to Medicare as a percentage of Medicare. So you know, there's a lot of analysis that has to be done. This was a piece of guidance that they gave, just a summary. They said, what do you do and what don't you do? The do's, you have to do a detailed, thorough analysis, follow the guidance, right? This guidance here. Include all of the data processes and strategies that you're using to limit care, anything that you're using, and make it come to well-reasoned conclusions. Obviously, it's assumed that if you find violations that you fix them. We're certainly finding them, you know, as we're looking. TPAs have gotten themselves in quite a pickle because in a lot of situations, they have created the plan document and given it to the plan, to the employer. The employer has adopted that, and now it's out of compliance, but they never circle back to tell them. That's no bueno at all. That certainly causes a problem. Other don't be vague. Don't disregard the contents of this requirement, and don't assume that the TPA is compliant and doing all this stuff for you. Candidly, the TPA is not going to do this for you. They at least right now that we're seeing, they're not doing it. What are the risks? I talked about the TPAs who have written the plan documents. The other big risk is something they call global enforcement. This is a pretty terrifying thing I discovered, but they sounds like they kind of use it. This is sort of what they do. Let's say that you're with ABC TPA, your client is, and or let's say that you're a broker and you have 10 clients there. Well, they find one of those clients not compliant. They'll go, hey, we can correct a lot of stuff. Let's just go to this TPA. Let's just go audit every one of their clients. Now that sounds terrible, you know, from a business standpoint. To me, that's a risk that's just awful. What about for the plan sponsors themselves? There are state penalties more and more that are coming. There's certainly DOL scrutiny. I'm going from the bottom to the top. There's certainly the good old penalties, $110 a day per member. That's not inconsequential. But I'll tell you, from what I've seen, member lawsuits by far are the biggest risk. This is something that I would strongly recommend people to make sure their fiduciary liability is, you know, for our clients, we're making sure that we're talking with them about it. Simply put, you have limitations on a plan that prevents someone from getting care. They then have something happen to their mental health, you know, something tragically happened to them, what have you. Or if the DOL comes in and finds out that you are not compliant, and then they notify all your plan members, which can happen, you might find yourself into, this has happened on the retirement plan side, you might find yourself in class action as well. Bottom line, as a business owner myself, going out of business over something is a bad idea, especially when you can fix it. When you can do the work that's necessary to be able to get it taken care of. So what are an employer's options to do this? It really comes down to 4, I think. You can get your TPA to do it. We're not seeing any TPOs who want to touch this with a 10-foot pole. You can get your broker to do it. Brokers don't really like that idea. You guys are doing a lot. You can do it yourself, which is daunting to say the least, or you can hire someone. You can hire a vendor. Those are kind of the deals that you're looking at in terms of pricing of what we charge. You can, again, this is NQTL analysis.com. You can go to pricing. we charge, and this is obviously subject to change, but as of right now, we charge $39.99 per year. For some TPAs, that are in certain situations, there can be a discount of maybe 10%, but it's pretty much that. And it's going to be, we're not as certain what the renewal rates will be. It'll probably be a little bit less, but this kind of goes through the entire service detail. Basically, what we're doing is we're getting people compliant with this and keeping them up to date as we move forward with additional guidance. All right, so I'm going to go to some questions. Take a look here. Some really good feedback. I appreciate that. Plan document review. Yes, we are reviewing the plan document. We are not attorneys. We're not going to give you legal advice on this. Very similar to ACA reporting. Our approach on this is, if you want an attorney to do all that, you certainly can. You're gonna pay for it. It's pretty expensive right now. But we certainly are reviewing everything in regard to treatment limitations and to the non-quantitative treatment limitations. That's the stuff that we're focused on. If you need your plan document rewritten or something like that, we can help you. We have an attorney that can that can do it for you. It's not our staff attorneys, but it's who we work with. Let's see here. All right, this is a good one. How, do you have to provide this reporting to members? And the answer is upon request, as well as obviously to the DOL upon request. But we do think some reporting is coming. So here's the question. Who in the world would ever request it? Why would a member ever request it? All right, so I'm gonna answer that question with a question. Have you ever heard of a provider paying COBRA rates on behalf of a member? All right, so like for instance, a person has, they have kidney failure, end-stage renal, and they're on COBRA, and the provider goes, they said, yeah, I can't pay my deductibles and everything, whatever. And so the provider's like, I'll pay your COBRA payments. I'll pay those premiums because I'm going to get the money on the backside. This is the same thing, guys. Providers are getting wise to the fact that this is all about making sure that they're getting paid, quote unquote, the type of revenue that is fair. Hopefully they won't misuse that, but in the marketplace, history has told us that's how they're going to do it. So it's not even that the member may necessarily look at it. They'll request it, give it to their to somebody who's a lot more astute than them, who will be looking at this kind of stuff. So we actually do anticipate that, as more and more of the providers understand this, that you're going to see this a lot more. In terms of the number of plans, I don't know if we have this in here. Yeah, our standard in pricing includes one TPA, one PBM, one medical network, one medical management and utilization vendor, and up to 3 different medical plans. So in other words, that's what most people, right? But let's say you have 6 different plans. Okay, we're going to have to add a little bit. I think we're adding right now like $250 per additional plan. It's just more work, right? If you have another TPA, it's probably going to be a little bit more, but it's our standard deal that handles 95% of all clients. This pricing should be good to go for you. Yes, we do assign account managers. Your account managers, we have a pretty process that's getting more and more refined as we're doing it, but very similar to how we've done ACA reporting. We at ACA reporting service, if you guys, let's see here, ACA, hard to type with one hand. It's very similar to how we do stuff here. But we're bringing people on. We do a discovery session, and then we start to a lot of it then becomes, all right, we need to get with the TPAs and the PBMs. We need to ask a lot of questions, come back with an analysis of this is what you need to do, and then obviously this is an ongoing thing. We're touching base and keeping it ongoing compliant. Question. Yep, this is the cost just right here. You just go to pricing. If you need a proposal, yep, there's a question about that. Up here at the top, you see that frequently asked questions. Just click on proposal. This is a proposal that has everything that that you may need. Okay, trying to see. Okay, there's a pretty detailed question about refusal to pay, PBM refusal to pay. Bottom line is yes. That's the kind of stuff that we're talking about. Is that standard being applied to medical and surgical in the same way it is mental health and substance use? If so, then we're good, but we still have to document it all out. We still have to have the overall comparative analysis. All right, I think I wore you guys out. I don't know that I have any more questions here. I'll give it just a second. Otherwise, as I'm clearing up here and finishing up, NQTLanalysis.com, the blog will keep you up to date with a lot of the stuff that's kind of going on from time to time. Frequently asked questions, though, this can be a good resource for you. But thank you, guys. I appreciate your time, and please let us know how we can be of assistance. Have a great day. Thanks.